Hello and welcome to a new episode of NeoMed AI podcast, the podcast that offers insightful AI for better neonatal care. I'm your host, and today we're tackling an age-old but ever-evolving challenge, neonatal hypoglycemia. Now, low blood glucose might sound mundane. You see it on the postnatal ward, you see it in NICU, you even hear it murmured in clinic corridors. But the new 2024 British Association of Perinatal Medicine Framework has shifted the goalposts. It's no longer just below 2.6 mmol per litre panic. Context now rules: who the baby is, what signs they show, and how numbers change over time. Here's our roadmap. We'll start with the fundamentals, definitions, risk factors, and those pesky operational thresholds. From there, we'll ground everything in real-world cases. A late preterm infant of a diabetic mother who's jittery on the ward, a term baby struggling to maintain glucose on an infusion, and finally, a diagnostic conundrum that hints at congenital insulinism. Along the way, we'll share pearls, pitfalls, and a few consultant-level curveballs. By the end, you should feel ready for that 0-3 hill prick that makes the whole ward hold its breath.
Thrilled to join you. Hyperglycemia is bread and butter in neonatology, but the devil is in the detail. I'm hoping to turn that detail into something memorable and actionable for everyone listening.
Let's start with the why. For the junior doctor or the new midwife on postnatal, it can feel like we measure glucose because we do. What's the harm in a transient dip?
Good question. The newborn brain is a voracious consumer of glucose, about twice the rate, gram for gram, of the adult brain. When supplies falter, neurons flip to alternate fuels like ketone bodies. Now that's fine in a term infant with intact ketogenesis, but in a preterm baby or a hyperinsulinemic infant of a diabetic mother, ketone production is blunted. Prolonged or recurrent low glucose then deprives the brain of both its primary fuel and its backup, leading to excitotoxic injury, particularly in the parietal and occipital regions. Longitudinal studies link severe or unrecognized episodes to motor deficits, lower cognitive scores, and even visual cortex damage. So those decimal points really do matter.
All right, let's bring in our first case. Imagine this. You're the SHO covering the postnatal ward on an unusually busy evening. A 38 plus 5-week boy, born to a mother with diet-controlled gestational diabetes, has just had his routine check. He's unusually lethargic and a bit floppy. You do a heel prick on the ward gas machine, and it flashes 1.8 millimole per litre. Walk me through, is that an emergency or a feed him and see situation?
Under the new BAPM Framework, we use operational thresholds. For a symptomatic baby, jitteriness counts. Any glucose below 2.5 millimoles per litre demands immediate action. And if the number dips below 1.0 millimoles per litre at any time, that's a red flag regardless of symptoms. Our lad is at 1.8 with symptoms, so yes, medical emergency.
So what are our first line moves?
3 steps, almost like muscle memory. 1. Admission to a monitored setting, usually NICU or at least transitional care with cardiorespiratory monitoring. 2. Intravenous bolus of 10% dextrose at 2.5 milliliters per kilogram. The dose used to be 2 milliliters per kilogram, but we now aim higher for a more decisive lift. 3. Continuous infusion starting at 60 milliliters per kilo per day of 10% dextrose. That's about 4.2 milligrams per kilo per minute. Then reassess glucose in 30 minutes.
And for the folks thinking, hang on, can't we just put baby to breast first?
I admire the breast-first ethos, but once symptomatic hypoglycemia hits, time is neuronal tissue. Feeds are supportive but too slow for an unstable number. The rule of thumb: if symptomatic or less than 1.0, you go straight to IV. Feeds continue in parallel once baby is stable.
All right, screening protocols are the front line. Under the new guidelines, who makes it onto the screening list?
Risk groups can be divided into 3 buckets. Maternal factors, diabetes or beta blocker therapy during labor. Neonatal factors, preterm less than 37 weeks, fetal growth restriction. And perinatal stress, hypothermia or perinatal asphyxia. The golden rule is to make sure the first feed happens in the first hour of life, then check within 2 to 4 hours, unless symptoms demand earlier.
For everyone scribbling notes, can you give 2 pearls and 1 classic mistake?
Pearl 1, early feeding is neuroprotection. Encourage skin-to-skin and colostrum expression while baby is still in the birth room. Pearl 2, use operational thresholds, not rigid numbers. The story behind the low matters, symptoms, risk factors, and trajectory guide urgency. Pitfall, jitteriness alone doesn't equal hypoglycemia. Check temperature, calcium, and rule out withdrawal or hypoxic events.
So back to our lethargic 38-weeker, 30 minutes post-bolus and infusion, his glucose comes up to 2.4 mmol per litre, better, but still under the 2.5 symptomatic target. What adjustments do we make?
Escalate by increasing the glucose infusion rate, often about 2 milligrams per kilo per minute. You can achieve that by upping the pump rate or moving to 12.5% dextrose via a peripheral cannula if your unit's policy allows. Recheck in another 30 minutes, and don't forget supportive measures. Keep him warm, maintain normoxia, and watch electrolytes.
And if you can't get a line?
2 rescue options: 40% buccal glucose gel at 200 milligrams per kilogram, rub into the cheek mucosa, or IM glucagon, 200 micrograms per kilogram if gel isn't available. They're bridges, buying maybe 20 to 30 minutes.
Case 2. A term female, birth weight 3.5 kg, mum received labetalol for PET. On day 1, she's feeding like a champ, but routine pre-feed glucose is 1.9 millimol per litre. She looks fine. You feed, recheck another pre-feed glucose, and now it is 1.8 millimol per litre. Still asymptomatic, but numbers refuse to budge. Under the framework, what threshold matters here?
That's our third operational trigger: 2 readings below 2.0 millimoles per litre in an at-risk or screened infant, even if asymptomatic. She now requires intervention. You could try a feed plus buccal gel as first escalation, but if a third low reading follows, or feeds fail to push her above 2.0, then IV therapy and admission are in order.
Let's zoom out. How do these thresholds compare with American Academy of Pediatrics guidance?
AAP still references 2.6 millimoles per litre as a critical level for the first 48 hours, but it distinguishes between well and unwell newborns. BAPM took the bolder step to contact-specific cutoffs, partly influenced by the hypo-exit trial, which found no neurodevelopmental disadvantage when asymptomatic at-risk babies were treated at 2.0 rather than 2.6. So the UK has moved to a more nuanced, risk-stratified approach.
Assume she stabilizes on feeds after 1 dose of buccal gel, hitting 2.2 millimol per litre then 2.4 pre-feed. When can we stop checking?
After 2 consecutive pre-feed readings of greater than 2.0 millimoles per litre, if she remains asymptomatic, monitoring can cease. Parents can be discharged with the usual feeding support. For senior trainees, 2 advanced pearls and a single trap, please. Pearl 1, always draw a critical sample glucose, insulin, beta-hydroxybutyrate, cortisol, growth hormone before treating persistent or severe hypoglycemia. 1 shot only. Repetition after glucose correction is meaningless. Pearl 2, large for gestational age infants without maternal diabetes no longer need blanket screening. Redirect resources to those who benefit most. Pitfall, prolonging glucose monitoring indefinitely. If thresholds are met and risk factors have resolved, stand down to avoid needless hill pricks.
On to our last act. A 5-day-old boy, small for gestational age, has required escalating infusion rates, now at 9 milligrams per kilogram to stay just above 2 millimol per litre. You sent a critical sample during a hypoglycemic spell. Glucose 1.6, insulin detectable at 6 microunits per milliliter, ketones negligible. What diagnosis is knocking at the door?
This pattern screams congenital insulinism, where pancreatic beta cells overshoot. Persistence beyond 72 hours with high glucose demand plus inappropriately elevated insulin and suppressed ketones clinches suspicion.
Immediate management?
Raise the target. Greater than 3 millimoles per litre for the first 48 hours if you suspect neuroglycopenic risk, then greater than 3.5. That often necessitates 15 or 20% dextrose via a central line, maybe glucagon infusion or dioxide once confirmed after a discussion with the regional hyperinsulinism center.
Let's stir the pot. Some clinicians still treat every low less than 2.6 mmol per litre aggressively, worried about subtle cognitive harm. Where do you stand?
Nuance is the word. Evidence shows brief, asymptomatic dips in well-term babies rarely harm if they self-correct. What matters is duration, severity, and the baby's ability to generate ketones. So rather than chasing numbers in isolation, I prefer a holistic lens: risk factors, clinical signs, response to feeds, and whether ketogenesis kicks in. Overtreating inflates admission rates, interrupts bonding, and may expose babies to line-related sepsis.
Quick detour. How does all this translate to low-resource settings where glucometers are scarce and lab turnaround is slow?
Great point. In many such settings, dry blood spot glucose or point-of-care devices with wider error margins are realities. Emphasis shifts the clinical assessment. Poor suck, lethargy, temperature instability, and empirical dextrose gel becomes vital. Community health workers can be trained to recognize danger signs and administer gel while transferring to higher care.
Before we wrap, what tech or research avenues excite you?
Continuous glucose monitoring for neonates is advancing. Sensors calibrated for low ranges could revolutionize surveillance by reducing heel pricks and capturing nocturnal lows we currently miss. Trials are underway, though miniaturization and skin fragility remain hurdles. Also, exogenous ketone therapy is being studied as a brain-sparing adjunct in severe hyperinsulinism.
Time to land the plane? 3 essential take-homes. 1. Operational thresholds reign supreme. The number alone means little without context. Symptoms, risk factors, and trends dictate urgency. 2. Act fast, but sample smart. Secure a critical sample at the first severe or persistent low, then treat with IV dextrose without delay. 3. Persistent high requirements warrant escalation. Think congenital hyperinsulinism. Raise glucose targets and involve specialist teams early. Thanks for joining us on Neomed AI podcast. And just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.